Hello and welcome to our listeners from around the world. This is JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Nikki Hastings and Dr. Valerie Smith about geriatrics-focused versus traditional primary care in the Veterans Affairs healthcare system. Welcome to the both of you. To start, can you please introduce yourselves?
Hello and thank you. My name is Nikki Hastings, and I'm Professor and Chief of General Internal Medicine at Duke University and Director of the Center to Accelerate Discovery and Practice Transformation at the Durham VA.
Hi, thanks for having us here today. I'm Valerie Smith. I'm an associate professor in the Department of Population Health Sciences at Duke University and a biostatistician researcher at the same VA Health Center as Nikki.
So I wanted to start by just saying that I really enjoyed reading this study, particularly as there have been so much more of a focus on patient-centered medical homes. With that context in mind, can you give us a bit of background on the concept behind this study?
Broadly speaking, our team was interested in understanding how we could better meet the needs of the growing population of older adults with complex care needs, and particularly in the context of a limited supply of geriatrics trained clinicians. So, we hear often about the growing number of older adults in this country and worldwide, but less often the focus on how they often have multiple physical, cognitive, and social challenges that can be interacting and really create special challenges for providing them with optimal health care. In particular, we really felt like there was an evidence gap around understanding the effects of care models that were designed to provide longitudinal ambulatory care or primary care for this population. And that's really what motivated us to think about designing this study. I will say we were particularly interested in doing this work in the Veterans Affairs healthcare system for two key reasons. One of those is that this is really an imperative for the VA healthcare system to understand how to better meet the needs of aging veterans. Of the more than 16 million currently living veterans, nearly half of them are age 65 and older. And the second reason is because VAs have long delivered care through PACS, PACTS, or patient aligned care teams, which are built on the concept of patient centered medical homes that really emphasize team based care. So, studying this issue in the Veterans Affairs healthcare system really gave us an opportunity to look specifically at geriatrics focused care versus a very robust existing primary care model in the PACT model.
Can you give us a brief overview about what you did in this study?
We first determined what kind of exposure to each of these two systems we wanted the veterans to experience for us to understand exactly what we were measuring the effect of. So we wanted to have this sort of 12-month transition period that we refer to in the paper as the exposure period, where veterans either had at least 2 visits in this geriatrics model of care, or they had at least 2 visits in this traditional model of primary care, referred to as PACT. And then we also wanted to gather the patient experience. This would have been something that we could have just looked at administrative health record outcomes, but we felt it was really important to understand from the veterans' perspective what they felt about their care in the 2 different models as well. We also wanted to get a national perspective, so not just one health system, but we wanted to look on average across the entire country. How is this model of care working, knowing that it might be implemented slightly differently within the same general parameters in different locations to get that natural variation that happens across the country to add some robustness to the results. So we identified patients who had these sort of 2 patterns of exposure, either having at least 2 visits to GeriPACT in this 12-month period or at least 2 visits to PACT in the same 12-month period. And then we wanted to find veterans in each of those that were comparable, so that really we're trying to isolate the effect of what is the difference only because of this model of care. So we tried to find veterans who were similar on age, sex, race, likelihood of hospitalization, number of hospitalizations they had had prior to exposure to these 2 models of care. Then we called and recruited them, first recruiting the patient who was in the GeriPACT model of care. And then after we enrolled someone in the Geriatrics model of care. We called someone who looked like them, except for the model of care, who was receiving the PACT care, and surveyed them about their quality of life, their perceptions of care integration, and repeated those assessments every 6 months over 18 months to try to understand, going out 18 months after this first exposure of transitioning care to Geripact versus staying in traditional primary care. How were patients experiencing this? How were they doing in things that we can't measure in the health record, in addition to things that we can, that we collected in the health record?
And what were the main results of the study?
Our primary outcome in the study was home time, defined as days not in a hospital, nursing home, or inpatient rehabilitation facility or emergency department. And we found no difference in home time for patients that were cared for in Geripact versus patients that were cared for over the same time period in the traditional patient centered medical home in VA. We looked at patient experience measures as well and did not find differences there. Where we did find substantial differences were in quality of care measures. So we looked at assessment of falls, incontinence, function, for example, and in each of those cases, the odds of having those assessments completed were much higher in Geripact than in PACT.
This is a really interesting study, and there's an excellent invited commentary that accompanies it, which notes that the usual care delivered by PACT was already very involved, which could be one reason that there was ultimately no difference in that primary outcome between interventions. I'm wondering if you could speak more to this point.
I think that's a really important point and really critical for interpreting the findings of our study. As we mentioned earlier, VA has long been a leader in delivering primary care according to the patient centered medical home model. And so, really, here we were looking at a model of care, the Geripact, which mirrors the PACT model in many ways in focusing on interprofessional team based care. What it provides in addition to that is geriatrics focused expertise, somewhat smaller panel sizes, and some more access to other types of team members such as social work and pharmacy. If we had tested this model against a different comparator condition when the primary care that was being delivered was less robust, or perhaps for patients that didn't even have really well coordinated primary care, the results might have been different. And in fact, when we looked at the literature in this area to provide our own context for the findings, we found that a lot of the models that have shown differences in looking at more intensive primary care models have been compared against less robust primary care models. So I do think that's an important point in considering our findings. I think the data bears that out as well, because, for example, in the outcome looking at assessment of function, in the Geripact arm, the estimated probability of having a functional assessment completed in the traditional primary care arm was 74% compared to 92% in the Geripact arm. So that's a big jump, and nearly every person in Geripact is getting the screening, but 74% is also a pretty high starting point. So I think that does bear out the point that you're making that VA primary care was already being delivered with a pretty high standard.
I think that's a great point. It makes a lot of sense. And I wanted to just take a moment to highlight something you mentioned where patients that were in the Geripact intervention group did have a higher odds of receiving, appropriate screening and assessment. And I wonder if you could speak more to this point, perhaps in the context of future work that could be done or should be done in this area.
This study has made us reflect a lot on time frames and time horizon for measuring exposure to something like a primary care model. The way that our design was set up, which Valerie explained earlier, is that we looked for patients that transitioned their care from traditional to Geripact, and then we looked at their outcomes over 18 months. So we're really only able to comment on the effects of Geripact within the first 18 months of exposure to that model. We did find measurable differences in the assessments, for example, but I think it has really made us ask some hard questions around how long should it take to see outcomes in other outcomes like home time, if they are in fact there, or if there is a benefit like that to be realized from this model. So, for example, to your point about future research, I think one of the really critical things is to think about looking at a longer time horizon to see if the higher rates of assessments that we're observing, for example, turn into outcomes that can be measured more concretely down the road. The benefit of screening for geriatric syndromes ultimately depends on multiple things like the positivity rate and the action steps that are taken in response to those positive findings. And we didn't really assess those in the context of the current study, but those would be things to look at, as well as examining the longer term durability of these findings and whether any of the other outcomes are different when measured over a longer time frame.
Before we wrap up, are there any final thoughts regarding this topic or this study?
A side benefit to a lot of the thinking that went into this project was coming up with a study design that really allowed us to get the patient perspective when we're thinking about evaluating programs, policies, really anything on a large scale level that we aren't able to randomize. We're, as researchers, frequently thinking about this in terms of non-randomized observational big data studies, but those often leave out the patient perceptions and the patient reported outcomes that are really crucial sometimes to fully understanding things like a model of care and other things that we might want to evaluate. And so I think that the thought that went into this about how to really find comparable patients and the logistics of recruiting in dyads to survey patients to get their experiences of care to compare them was something that we're hoping to transport and use in other studies and future evaluations of different policies and programs.
I think that's a great thought to end on. Thank you so much to the both of you for speaking with me today about this very pertinent, very relevant topic. I'm Dr. Angel Desai and have been speaking with Dr. Nikki Hastings and Dr. Valerie Smith about geriatrics-focused versus traditional primary care in the Veterans Affairs healthcare system. You can find a link to the article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.